Leaks, their diagnosis and treatment by Dr. Peter Hallowell of University of Virginia.
Thank you, Dr. Shermer and Dr. Sherman. Disclosures. So gastric bypass is now one of the most commonly performed operations for obesity in the United States. As we heard earlier, it's about 180,000 to 220,000 bariatric procedures performed per year. So you're doing the math, it's about 100,000 gastric bypasses every year in this country. We've been able to decrease the morbidity quite well with this operation in most large series. Mortality from the operation is 0.1 to 0.5%, and morbidity is in the range of 5 to 10%. This is a basic schematic of your gastric bypass with a roux limb, excluded stomach, and jejunojejunostomy. So one of the most feared complications after a gastric bypass is a leak. The incidence in the literature is reported to be about 1 to 5%. However, in more later series, the incidence is decreasing around the 1 to 2% range. Most leaks will occur in the first few days with a median of 2 to 3 days, but can occur at a range out to 30 days. Most of the leaks occur around the gastrojejunostomy or the pouch, around 50 to 60%. About a quarter of the leaks will occur at the distal stomach, and about 10 to 15% at the jejunojejunostomy or enteroenterostomy. Those leaks are some of the more difficult ones to identify and take care of. The problem with leaks is the diagnosis may be very subtle. Tachycardia, especially sustained tachycardia, 120 beats, 125 beats per minute, fever, tachypnea, abdominal or shoulder pain, oliguria, hypotension, and sometimes the patients will tell you they have an impending sense of doom or are highly anxious. Some of these symptoms may mimic a pulmonary embolism, and the treatment between the two are radically different. You need to really have a high clinical suspicion for a leak. Radiographic studies can be helpful, but they lack 100% sensitivity. The leak may be coming from a different area than what you can see on a swallow study and even sometimes with a CT scan. Your radiologist may or may not be any good. The position of the leak might be somewhere where they're not really able to see it. Negative radiographic imaging should never stop you from taking somebody to the OR to explore for a leak. If you think that the patient may have a PE, a rapid CT scan to evaluate for that and rule it out is certainly reasonable before going to the operating room. A re-exploration is the definitive test for a leak, so don't be afraid to do that. If you see here, anywhere that there's a staple line, you can get a leak. So along this area, the gastric pouch, the gastric remnant, this area along the gastric pouch and up to the angle of his, down along at the jejunojejunostomy, this entire mesentery and the cut end of the mesentery here, as well as the rest of the bowel, anywhere that's been handled, you can get a leak. Patients can have a wide clinical response. It might be a little bit of shoulder pain. It might be that nagging tachycardia. You can't really get your finger on it. You're giving them some pain medicine. They have a little oliguria, but they're otherwise relatively stable. These are certainly people that you can begin to investigate and see what you're dealing with. In general, patients that are having hemodynamic compromise or collapse need to go to the OR and find out what's going on. The safest place for a bariatric patient, post-bariatric surgery with this clinical response is going to be in the operating room. And in general, early operative intervention is going to decrease the septic response and may prevent a mortality in these patients. So this is a gastrographin study in a patient that I had early post-operatively, very difficult operative case. And what you see is the pouch, contrast in it, and then this stream of contrast coming out over above the spleen. This is a patient that we had already put a gastrostomy tube in due to her difficult operation, was hemodynamically stable, and we were able to manage this one non-operatively. Here's another one of our patients, again, sort of the same picture. You have the contrast in the pouch, and then this stream of contrast coming out above the spleen that's free. So this is another radiograph showing the position of the contrast in the leak, and it's very subtle, but this is one that we treated with a stent, which is running right in this area. In most cases, operative intervention is the most appropriate course. This can be done either laparoscopic or open, depending upon your skills and your operative findings. A primary repair of the site of leak, if possible, is generally recommended. Drainage of that area with closed suction drainage, and then enteral access, generally with a large gastrostomy tube placed into the distal stomach, allows you to feed the patient, and if the leak is at the gastrojejunostomy, help their progress along. Percutaneous drainage for small leaks is acceptable in stable patients. However, if you have any question, operative therapy is the best way to go. Endoscopic stents. This is kind of new on the area. Been the last few years. This is an off-label use of the stent. They are effective at controlling and healing leaks. The major downside to the stents are stent migration, moving from the position that you put it in. This is best used with an experienced endoscopist, and hopefully not the first time through. Here's a picture of our patient with a continued leak at the site despite reoperation, and you can see a drain over here. And another example of a placement of the leak. This is from the first patient. You can see right along here is the stent. Over here is our percutaneously placed drain, which got rid of the contrast, and you can see there's no leak of the contrast in this study. We left this stent in for about 3 weeks, pulled it out with complete resolution of the leak. So in conclusion, have a high index of suspicion for leaks. Although they are infrequent, the consequences may be deadly. Do not rely solely on radiographic intervention. This could get you into a fair amount of trouble. When in doubt, operate. I prefer to drain and provide enteral access, and endoscopic stents are something that may be very useful in the future. Thank you.